For decades, the dominant view of heart disease followed a simple mechanical logic. If an artery clogged, the solution was to force it open. Historically, this intuition led clinicians to the catheterization lab, automatically deploying a stent to physically restore blood flow and, theoretically, prevent a future heart attack. This chart shows the survival data from the COURAGE and ischemia trials. For patients with stable coronary disease, the survival curves for those receiving stents and those on medical therapy remain totally superimposed. Routine revascularization did not reduce all-cause mortality. Surveillance of the COURAGE cohort, drawn largely from the U.S. Veterans Affairs system, tracked these outcomes for up to 15 years. The evidence confirmed a persistent clinical equipoise. Stents offered no survival advantage over medication alone in this population. If a mechanical fix doesn't automatically save a stable patient's life, how do cardiologists determine which patients actually need them? Managing heart disease has evolved from a reflex action into a specialized process of navigating a data-driven clinical stratification matrix. The first pathway in the matrix covers patients with single-vessel or low-complexity stable coronary artery disease. For these individuals, upfront surgery is often skipped in favor of intensive lifestyle interventions and guideline-directed medical therapy. Research led by Dr. Dean Ornish showed that a comprehensive lifestyle program built on a whole foods vegetarian diet and exercise could induce angiographic regression of disease, and a 72. The EVADE-CAD trial later tested these nutritional effects under randomized conditions, demonstrating that a vegan diet could drop the inflammation biomarker hsCRP by 32% in just 8 weeks. In stable patients, aggressively modifying internal vascular chemistry is a primary treatment strategy rather than a secondary preventative measure. While lifestyle changes are potent, patients must navigate a landscape of conflicting information regarding long-term maintenance. Some reports claim that a specific diet can drop the rate of in-stent restenosis, the re-narrowing of the treated artery, to just 2%, but these figures are not supported by peer-reviewed primary data. Modern clinical practice relies strictly on proven biological pathways that have been validated through randomized controlled trials. This diagram illustrates one such pathway. Plant-predominant nutrition alters the gut microbiome, reducing the production of TMAO, a gut metabolite associated with macrophage foam cell formation and platelet hyperreactivity. These interventions are biologically effective, but their clinical authority depends on adhering to the limits of what the randomized data can prove. The matrix takes a different turn for patients with diabetes, severely reduced heart function, or anatomically complex multivessel disease. In these specific cases, biological risk is too high to rely on pills and diet alone. Mechanical intervention is required to secure the patient's future. To decide the tween treatment modalities, trials like Syntax, MASS2, and Freedom pitted stents directly against coronary artery bypass grafting, or CABG. For complex cases, data favors surgery. This chart shows CABG offers a significant long-term survival advantage over stents at 5 and 10 years. The Freedom trial highlighted a widening survival gap for diabetic patients, where bypass resulted in significantly lower death and myocardial infarction. When the disease architecture is severe, routing blood around diseased segments via bypass becomes the most durable way to ensure long-term survival. Coronary artery disease progresses as a systemic, whole-body vascular illness. Localized mechanical fixes, like stents or grafts, do not halt the underlying disease process occurring throughout the rest of the arterial tree. Without systemic management, even successful surgeries eventually fail. Approximately 50% of saphenous vein bypass grafts occlude within 10 years. Maintaining graft patency requires aggressive pharmacotherapy, using statins or PCSK9 inhibitors to drive LDL cholesterol to very low levels. Modern secondary prevention integrates these powerful drugs with the intensive dietary and behavioral changes shown to improve vascular reactivity. Major institutional guidelines now mandate this combined, multi-pronged approach for all patients following a revascularization procedure. True survival is not a choice between a scalpel, a pill, or a diet. It is the simultaneous deployment of all three to win a systemic war.